Okay, so now we're going to talk about Parkinson's disease, and this really should have been in the neurological lecture, but that lecture was getting too long, so I moved it to the spinal cord lecture. So with Parkinson's disease, this is characterized by resting tremors, which is different than multiple sclerosis because multiple sclerosis, they have intentional tremors. Resting tremors happen at rest. Intentional tremors happen when you go to do something, like you go to take a drink or something. That is an intentional tremor. Parkinson's disease is also characterized by slow movement. This is called bradykinesia. Okay, they're going to have stiffness. Often it's called cogwheel rigidity, which means I don't know if you've ever tried to take a shirt off of somebody with Parkinson's. They can get really rigid when you're trying to do that. They can have balance problems, so they're going to be fall risk. They have problems with their blood pressure, their heart rate. They're going to be very fatigued, and they could have constipation. The reason for Parkinson's disease, it's a progressive degenerative disease that is caused by gradual loss of the nerve cells in the substantia nigra. And these nerve cells usually release dopamine. So it's from a lack of dopamine, because dopamine usually relays messages and helps us with our coordination and thought. There's also nerve endings that secrete norepinephrine, so the patient is fatigued easily and may have changes in their blood pressure and heart rate. With Parkinson's disease, there is a genetic risk factor. Chemicals can also cause Parkinson's disease, and this would be like pesticides. Um, they have been linked to Parkinson's disease. So obviously, you should tell anybody that has one of those jobs to make sure they wear all the protective gear. Heavy metals may also put a patient at risk for Parkinson's. Anybody that's had a traumatic brain injury is at risk for Parkinson's. Diabetes, of course, diabetes is a risk for a lot of diseases we talk about. And those with metastatic skin cancer are also at risk for Parkinson's disease. You can remember some of the cues by the mnemonic B SMART. So B stands for bending or forward tilt. So it's often called a stooped posture. S stands for shuffling gait. They have a shuffling gait, meaning their feet shuffle on the floor and they kind of speed up as they go. So ask me to demonstrate this in class and I can do this well for you. M is mask-like face. So their face is like a mask, like their effect is not they don't move their face. A is for akinesia, so that means lack of movement. R is rigidity, and I talked about cogwheel rigidity. And T is for tremor, and it's a resting tremor, most commonly described as pill rolling. Like you'll see patients sitting there with their arms, on their legs while they're sitting in a wheelchair, and you'll notice their thumb and their index fingers, they're doing like a pill rolling movement. Recognizing cues, again, the signs and symptoms. So the triad is the resting tremor, bradykinesia, and rigidity. Stoop spot, posture, shuffling gait, and mask-like face. Those are the most common signs and symptoms you're going to see. Again, recognizing cues. Remember, this is a progressive disease. So as the disease progresses, the cues are going to get worse, so to speak. So like drooling, dysphagia, that means trouble swallowing. I've taken care of several patients with Parkinson's disease who have died from aspiration pneumonia. So you have to be extremely cautious when feeding somebody that has progressed to the dysphagia stage and is drooling a lot. So they have that difficulty swallowing. They need to be evaluated by a speech language therapist and put on, so they can do a swallowing study to see what kind of foods are best for them. Diaphoresis, flushing, and orthostatic hypotension. People can lose their sense of smell like 20 years before they develop Parkinson's disease. Safety is going to be the most important goal to have. You want to keep the patient safe. Their risk for aspiration, I talked about that. Most patients with Parkinson's die from aspiration pneumonia. So make sure you're doing all the things to prevent aspiration, like sitting up, tilting their head forward when they eat, not letting them use straws. Um, they're also at risk for falls. So do all your fall precautions and wandering. So we talked about the interventions for aspiration, falls, pneumonia, and wandering in Med-Surg 1 when we did the dementia lecture. So make sure you review those interventions. We talked about interventions of taking care of someone with a progressive neurocognitive disease. And a neurodegenerative disease is very similar. So please go to your Parkinson's disease chapter in your Med-Surg ATI textbook and read about patient-centered nursing care. It's all the things you learned in fundamentals and also in Med-Surg 1 when we studied dementia. Okay, Parkinson's disease is managed with medications. They must be given on time. You can remember them from the mnemonic SALAD. Silagine is a MAO inhibitor, so you need to understand that you can't give these with taurine-rich foods, or they're going to get malignant hypertension. Anticholinergics, make your mouth dry. Levodopa and carbidopa. Imanitin can make people have insomnia, so make sure you're giving that early in the day. And dopamine receptor agonists can also be used in the treatment of Parkinson's disease. Here's the food to avoid when on a MAO inhibitor. Aged cheeses. So this doesn't include cottage cheese, so make sure they're aged or hard cheeses. You can read through the rest. I think you probably remember from pharmacology what you're not supposed to eat, but this is always like highly tested, so make sure you really understand what they can eat. All right, the next condition we're going to talk about is peripheral neuropathy, because this is very common. It could be due to stress and inflammation. The most common reason people get peripheral neuropathy is due to diabetes. It could also be due to an autoimmune disorder. It could be a vascular problem, like we talked about the difference between um, peripheral arterial disease and peripheral venous disease last semester. So somebody with peripheral arterial disease can develop peripheral neuropathy. Chemotherapeutic agents can cause it. Viruses like shingles or Lyme disease can cause it. And of course, smoking and obesity can cause peripheral neuropathy. And peripheral neuropathy is a major safety issue. So peripheral neuropathy is going to cause motor nerve damage, where it usually affects walking, talking, balance, and coordination. So they always have they might have difficulty moving their toes. They might have foot drop. They might have weakness in the hands or cramping. Okay, so they're going to be fall risk. Sensory nerve ending damage. They could, it affects their ability to feel vibrations, temperature, or pain, or touch. So you have to make sure that the water tanks in their home are set to 110 degrees Fahrenheit. Like, in other words, the water temperature is never going to go higher than that because they can't really feel. And they'll have impaired balance and coordination, so that's going to be a problem, and they develop foot ulcers, which sometimes they can't feel. And then autonomic nerve damage means that they're going to have constipation or diarrhea. They're going to have sexual dysfunction, sweating or no sweating, and heart rate and BP irregularities. Guillain-Barré syndrome is a rare immune-mediated polyneuropathy disease. It affects the spinal nerves, and it can also affect the cranial nerves. The cause is not really known, but it usually happens like this. Somebody has a viral infection or a respiratory infection or a GI infection, or perhaps they've had the flu shot in the last 2 to 4 weeks, and they start to develop these characteristic signs and symptoms. And usually they're going to need to be intubated for a length of time. They do recover from this syndrome, and then all is well. But you have to recognize it early to make sure they get the treatment they need. So the signs and symptoms of Guillain-Barré include numbness and tingling of the feet and hands. They can also get pain in the shoulders, thighs, and pelvis, and you have to put the scenario together. So somebody that's had a flu shot or somebody that's had a respiratory illness 2 to 4 weeks ago, now they present with these problems. They have ascending paralysis, meaning it starts in the feet, paralysis, and starts to move its way up. When it gets to the thighs, you have to start thinking about the respiratory muscles and that this patient may need to be intubated for a short amount of time. People with Guillain-Barré are going to need breathing support, so they'll be mechanically ventilated. They may also get something called plasmapheresis, which they take the patient's plasma from the blood and it's washed to remove all the antibodies. So that helps with recovery and usually decreases the amount of time they need with mechanical ventilation. They can also receive IV immune globulin, and then this is to shorten the recovery period. They're going to need tube feedings while they're mechanically ventilated. Oftentimes they may even get a paralytic ileus where which means there's no peristalsis, so then they would need like PPN or TPN. Most people with Guillain-Barré treatment do recover and they're walking within 6 months. All right, the next condition we're going to talk about is multiple sclerosis. Multiple sclerosis is a chronic, progressive, irreversible autoimmune condition. What happens is the myelin sheath, for some reason, there's a bunch of triggers, the myelin sheath is destroyed, which results in demyelination of the nerve cells. And when the nerve cells are demyelinated, it interrupts the conduction of impulses. It affects the optic nerve. That's why people with this condition have got scotomas, which is blind spots. If you remember from the eye and ear lecture last semester, they're going to have double vision. They have decreased visual acuity. Because it's an autoimmune disease, they're going to feel fatigue and pain. And because it affects the cerebrum, they're going to have memory loss, impaired judgment, and sensory deficits can happen as well, where they have vertigo and paresthesias. Because of the cerebellum is often affected, they may have ataxia, nystagmus, impaired coordination. They'll also have something called an intentional tremor, meaning when they go to grab something, their hands shake. Now, with Parkinson's, we learn they have a tremor, but it's a resting, meaning when they're resting, their hands will tremor, often in a pill roll motion. Okay? But with MS, it's an intentional tremor. The spinal, they may suffer from dysarthria and dysphagia as well. Bowel and bladder, they'll have that dysfunction. They can have constipation and fecal impaction, and they can have an overactive bladder. There are 4 types of MS. We're only going to focus on one because it's the most common. And when I think of MS, this is the type I think of. It's called relapsing and remitting multiple sclerosis. So what it means is that the client's going to go through periods of remission and exacerbation. So, for example, when they're triggered or when they have an exacerbation, they're going to have like new findings with loss of function. So another symptom, and then they have a loss of function. And then they can also have mild to moderate symptoms that resolved within a few weeks or months, and that indicates that they are remitting or they are in remission from MS. Triggers for exacerbation include extremes in temperature, like living in a cold climate or taking hot baths and showers. Those could trigger an exacerbation. Viruses, fatigue, physical injury, anything that you do that you're overexerting yourself. Fatigue and pregnancy can all cause an exacerbation of multiple sclerosis. The onset of MS typically occurs during the ages of 20 to 50 years of age. That's when you're going to be most at risk. Females assigned at birth are more at risk, and also if you have a first-degree relative with multiple sclerosis, you're more likely to contract multiple sclerosis. Recognizing cues, you can use the mnemonic demyelination. So D is for diplopia, so they have double vision. E is for eye movement, that's involuntary eye movements, nystagmus. M is for motor weakness and spasticity, so they can be weak and spastic. Y is for nystagmus again, okay, so that's important. E is for elevated temperature. L is for Lhermitte's phenomenon, which is what it is, it's they feel like they get an electric shock buzzing down their spine. Okay, so just randomly they'll get these electric shocks. Okay, N is for neuropathic pain, meaning pain because of nerves. A is ataxia, which is due to the cerebellum, effect. T is for talking slurred. I actually took care of somebody with MS when I was in nursing school. I was working as an aide, and he said that all his friends at work thought he was drunk when he was first coming down with this because he was walking funny and he had slurred speech. I is impotence and intentional tremor. O is for overactive bladder, and N is for numbness. They experience numbness and tingling in their extremities. For diagnostic tests, a lumbar puncture would be done. The CSF would be looked at for increased protein, increased WBCs, and then they would do something called electrophoresis to the CSF, and they would see increased lymphocytes and increased immunoglobulin G. The MRI, which is the most diagnostic for MI, it would show plaques of the brain and spine. And then they can do other tests too, like evoked potential testing. So it tests the optic nerves transmissions. But the MRI is probably the most important test to get, and then the CSF. As a nurse, you would monitor the visual acuity. It could be a fall risk if the visual acuity is declining. You would monitor speech patterns and, of course, swallowing. And you may have to have a speech language therapist evaluate the patient periodically as their disease progresses to make sure they're safe swallowing whatever type of food is ordered. They may have activity intolerance, so you want to recognize that and make sure they get enough rest. You're going to check skin integrity if they don't get up and around a lot to make sure they don't break down. You check coping mechanisms. The patient that I cared for early was very depressed. He was young. He was like 50 years old and he had MS. And he was in a wheelchair and he could get himself from wheelchair to the couch. So I would come over and help him with his ADLs. And then, he would sit on the couch for the rest of the day while his wife was at work and his kids were at school. So he was very depressed. It's a hard disease. So you want to also promote cognitive function. Now we talked about promoting cognitive function in the Alzheimer lecture that I gave you last semester. So make sure you review how to promote cognitive function. You may have to provide the patient with a communication board if their dysarthria is progressing and you cannot understand what they're saying. Some of the interventions involved with caring for somebody with an MS include encouraging fluids. They need to drink fluids because you want to flush out the urine in the bladder and you want to prevent them from getting a UTI because that may exacerbate their multiple sclerosis. They may have to engage in intermittent self-catheterization because of their overactive bladder. It may be hard for them to get the flow going. Or they may use Creday's method. Creday's method refers to pushing on the full bladder while you're sitting on the toilet to see if you can get the bladder to relax and then release the urine. They also need to be on a voiding schedule if they are still voiding, as opposed to incontinence or self-catheterization around the clock. So the voiding schedule can be every 1.5 to about 2 hours. And if they become incontinent, they may have to adjust their schedule. If they have diplopia, which is double vision, you can put an eye patch on so that they'll be able to hopefully see out of one eye. And then what you would do is alternate the eyes for where the patch is going on so one eye doesn't get weak. And then you have to teach them to scan their environment, because if they have like a blind spot or the visual acuity is decreased, they may not see things like shoes on the floor in their path. Okay, so teach them to scan their environment and stay away from crowds. The medications that are usually used for multiple sclerosis, you can remember with the mnemonic TGIF. They're disease-modifying therapies. Baclofen is a great antispasmodic medication given to people with multiple sclerosis. And you have to remember it can cause drowsiness, so it's a safety issue, and dizziness. Patient can become nauseated taking it, but the biggest thing is they can't stop abruptly, or their symptoms are going to magnify, and it could be very dangerous. So they need to taper over a 2-week period if they're taking baclofen. We're going to switch gears here and talk about spinal cord injuries. The most common cause of spinal cord injuries is trauma. During trauma, the patient can have a compression fracture and compress the spinal cord, and that could also lead to a spinal cord injury. You're never supposed to dive into a body of water if you don't know the depth. Risk factors of spinal cord injury include males from the age of 16 to 30 because they're very impulsive at those ages, and they tend to do some crazy things, okay? Falls in older adults. Older adults are often on medications that cause orthostatic hypotension. They may also be on blood thinners, so they can incur spinal cord injuries if they fall. And people who drink and choose to use illicit drugs, they're also at risk for spinal cord injury. To prevent spinal cord injuries, people should practice gun safety and lock up their guns. Wear seat belts, helmets. Don't use your phone while you're driving or using machinery. Trampolines need to be ground level, and don't let a lot of people on at the same time. Water safety we've talked about. So those are some of the things you can do to prevent spinal cord injury. I think not drinking and driving or using illicit drugs in driving is another good tip. But those are the things you can do. Spinal cord injuries can be complete or incomplete. The higher the injury, the greater the disability that the person's going to have. With complete spinal cord injuries, if you look at this picture, with paraplegia, which means part of the body is paralyzed, you can see here it looks like from the waist down, the patient is paralyzed, and it looks like they have some paralysis in their wrists and hands. And then if you look at the tetraplegia, which is the new name for quadriplegia, the person is paralyzed from the neck down. And then with incomplete spinal cord injuries, they can have varying degrees of deficits when they have that kind of an injury. So a complete spinal cord injury, sometimes what happens is the spinal cord is transected, meaning the injury goes all the way through the spinal cord. And when it's incomplete, when they have an incomplete injury, there's varying degrees of damage to the spinal cord. This is a great visual tool, this picture, for you to identify level of injury. People with a level of injury of C1 to C4 are going to be ventilator dependent because the phrenic nerve is in that area, and that innervates the diaphragm. Oftentimes, they die at the scene of an accident because they cannot breathe anymore by themselves. C1 to C8, they're going to have limited proprioception. And proprioception, I don't know if you've heard about this before, is your body's ability to sense its own position in movement. So if you lose this sense, you're not going to be able to maintain your balance. So they're going to be fall risks. They're at risk for injury. T1 to T8, This affects trunk movement and they'll have lack of abdominal control. Now, I need to mention injuries of T6 and above. They're considered paraplegics, but they also can suffer from something called autonomic dysreflexia, and we will talk about that later, but that is highly tested, so you're going to need to know that. T1 to T12, limited abdominal control, and then L1 to S5, they're going to have loss of bowel and bladder functioning and they could have sexual dysfunction as well. So to recap the level of injury, clients that have a injury in the C1 to T1 area have tetraplegia, which is the new name for quadriplegia. So they're going to have a loss of sensation, movement, and functioning from their head and their neck down to their legs, okay? C1 to C8, I talked about them losing proprioception, so they're going to be fall risk, obviously. It controls the neck, upper extremities, and internal organs. If they have an injury from C3 to C5, that controls the diaphragm. So we used to say C3, 4, 5, keep me alive. Okay, C4 and above are going to be mechanically ventilated for life. In C5, and a little bit lower in the cervical, they're going to be able to feed themselves. Some can drive, because they're able to manage a stick shift. Um, and then injuries to the T2 to S5, this is called paraplegia, and para means part, and plegia means paralyzation, so they're going to have part of their body paralyzed. So injuries to the thoracic region are going to affect the client's chest down to their legs and parts of their arms. So T1 to T8 usually affects trunk movement and sensation due to a lack of abdominal muscle control. Okay, and then T9 through T12 allow trunk control, but they have limited abdominal control. And then I had mentioned that T6 and above are going to be prone to autonomic dysreflexia, and we're going to go into great detail with that because that's highly tested. And then we talked about the lumbar and sacral areas are in control of the legs, bowel and bladder, and sexual function. And the spinal cord also is in charge of autonomic and somatic information. So damage to the spinal cord can cause bowel and bladder loss of control, and it can interfere with sexual functioning and could result in blood pressure fluctuations. This is the primary survey, which is also called the ABCDE framework. And if we have somebody that we suspect has a spinal cord injury, this is the framework we're going to use when we do our first assessment. It takes less than a minute to do. Okay, A is for airway. And this is where we look to ensure the patient has a proper airway. And if they're talking to you, their airway is open, right? But if they have obstructed breathing and you suspect a cervical spine injury, do not tilt the head back. You're going to do a jaw thrust instead. Likewise, if you suspect a cervical spine injury, the EMTs, whoever is on the scene is going to put a hard collar on, okay? And that hard collar does not come off until the provider gives you an order for that to come off. The patient will go, when they first come to the ED, to MRI and CAT scans to make sure that the spinal cord is intact, and the provider will give that order. With breathing, you're looking for the chest rise and fall. You need to take out your stethoscope and ensure that air is being moved, because people can have their chest move up and down without actually moving air in their chest. You're also going to look for tracheal deviation. That means the trachea is going to one side, because if you recall from Med-Surg 1, that could indicate a tension pneumothorax. Look for flail chest, and I'm going to talk about that at the end of the semester. C is for circulation. So we're assessing their pulses, the skin perfusion, and blood pressure if you have a blood pressure cuff at the scene of trauma. So this is where also they need 2 large bore IVs So they need, because if they go into shock, they're going to need a lot of fluids and possibly blood. So a large bore IV is a number 18 or higher. Okay, D is for disability, and this is where we assess the neuro status. So Glasgow Coma Scale is the most common method that they use to assess disability. And E is for exposure and environmental control. So you have to remember to prevent hypothermia, keep your patient warm in this phase. And this is also where you expose the patient to identify all injuries. So we call this the strip and flip stage. So you're going to cut off their clothes, you're going to roll them, and you're going to log roll if you suspect spinal cord injuries. That's very important. And until that cervical collar can come off, you're going to log roll the patient whenever you move them. Okay, so make sure you put warm blankets on them. And especially with spinal cord injury patients, they cannot handle extremes in temperature. When a client comes into the ED with a suspected spinal cord injury, a hard collar is put on around the neck. It's sometimes referred to as a Philly collar, and that doesn't come off until the provider has examined the CAT scans or any other test they've done to determine that it's safe to take this hard collar off. You have the patient wear this, and it can be a little uncomfortable for them, so you have to be firm and tell them you cannot take it off. Anytime somebody has a spinal cord injury, you look for a traumatic brain injury at the same time, and vice versa. You want to make sure you initiate spinal precautions, so the patient needs to be log rolled in one unit. After trauma, a client will have what's called spinal shock below the level of injury. So, for example, they'll have temporary loss of motor, sensory, reflexes, and autonomic function that occurs immediately after the injury. It could last 48 hours. It could continue for several weeks. Flaccid paralysis occurs below the level of the injury, and at this point, it masks the degree of spinal cord injury. So you're not going to know the true sequela of the spinal cord injury for a few weeks, until a few weeks after the injury occurs. You want to make sure that you maintain a mean arterial blood pressure of 85 millimeters of mercury to make sure that the spinal cord is being provided with perfusion and getting, that oxygen-rich blood. When spinal shock resolves, there will be a return of reflexes below the injury. And sometimes patients' families remark that they're starting to move their limbs again, but really they're just reflexes. Clients with spinal cord injury can also develop neurogenic shock, so don't get that confused with spinal shock. With neurogenic shock, this is really a true shock, whereas spinal shock is not a true shock. They just call it that because it's a shock to the spinal cord. So with neurogenic shock, the sympathetic nervous system is shut down. So the parasympathetic has to take over, and the patient's going to present with bradycardia. They'll have dry skin. They'll be hypotensive, and they'll have hypothermia. So people with spinal cord injuries have something that's called poikilothermia. So that means they can't regulate their temperature. So typically, they can take on the temperatures of the room you're in. So you always keep a spinal cord injury client's room warm, okay, because you don't want them to get too cold. But they can also experience hypothermia, so you need to watch out for that. DVT is a complication of spinal cord injury. In fact, many people with spinal cord injury die from pulmonary embolisms. It's one of the leading causes of death after a spinal cord injury. They're especially high risk the first 72 hours, and if they have neurogenic shock, they're going to be massively vasodilated. So that is also a reason that they are high risk for DVT, because the blood is stagnant because they're not moving like they normally would. There'll be a risk for life. You're going to monitor for DVT or venous thromboembolic incidents, and they're going to be treated with a low molecular weight heparin, such as enoxaparin, You need to start that within 72 hours, and they are going to be on that for about 8 weeks. And you're going to teach the family how to identify DVTs. So remember from Med-Surg 1, one calf could be larger than the others, could have edema, could have redness. They're not going to feel pain if they're paraplegic, depending on the level of injury they had. So remember those signs and symptoms to look out for. Another complication or complications include atelectasis and pneumonia. The patient with spinal cord injury is not going to be as active as they used to be, and depending on the level of injury, they could have weak chest muscles. So this may lead to atelectasis and then pneumonia. So to prevent this or to monitor for it, you're going to engage in data collection, listen to their lung sounds. You're looking for adventitious lung sounds. You also want to check their oxygen saturation frequently and temperature to see if they've developed any pneumonia. You're going to use aspiration precautions because they could develop what's called aspiration pneumonia. So make sure you're providing mouth care before and after meals, because if they have like food in their mouth and they swallow it, they could aspirate. But also, especially vent-dependent patients, a lot of germs are in your mouth. They need frequent mouth care so that when they're swallowing the saliva, if they aspirate it, they could get aspiration pneumonia. You're going to help them engage in coughing and deep breathing. You may have to suction the oral airway or the tracheal airway, PRN, if there's copious secretions, and they'll be hopefully going to physical therapy to strengthen their chest muscles. That can help prevent pneumonia as well. And if they do have pneumonia, make sure you're administering the antibiotics on time. Okay, so those are the ways you can prevent pneumonia as a nurse. Patients with cervical and thoracic injuries may need cough assistance. So with any spinal cord injury, you're going to do a respiratory assessment, Q4 hours, at least in the acute phase, and then it can go to Q8 hours. But if your patient cannot cough on their own, you may need to help them cough if they can't get their secretions up. So make sure the wheelchair is locked when you do it. Recline the wheelchair if you can. You're going to place your hands below the ribs. You can either use the hand, like the CPR method, where you put one hand on top of the other, or the other thing you could do is lock your thumbs and make like a butterfly with your hands almost, and put them under the rib cage. You're going to tell the client to take 3 to 4, 5 deep breaths. Okay, on the last breath, you're going to push in and up with firm pressure and ask the client to cough when they exhale. The GI complications of spinal cord injury include, at least initially, the patient may have a paralytic ileus, which will require a nasogastric tube to decompress the intestine and stomach. They may also suffer from stress ulcers, and definitely we want them on some type of GI prophylaxis, like an H2 antagonist or a PPI. And then anybody that gets mechanical ventilated, or is mechanically ventilated, I should say, is going to need stress ulcer prophylaxis. Stool softeners should be given to practically everybody in the hospital, but especially spinal cord injuries, because they're going to be immobile, and you need to increase fluids and fiber in the diet. You would give laxatives and enemas only when necessary. Upper motor neuron lesions are L1 and above. And how I remember spastic versus flaccid zone is when you're really up, you're kind of spastic. Okay, when your mood is really up, you're spastic. So that's how I remember that. And what happens with them is they can evac their bowel, but they may leak. Okay, so they may have some leaking of stool. And then lower motor neuron lesions are below L1, and they are going to have flaccid muscle tone. So the bowel will fill and become over distended, and the client will not be able to evacuate stool. So they are probably going to need digital stimulation. The important thing about digital stimulation is that you use a numbing medication, because even if the patient can't feel, some of the nerves may still be working and they can develop bradycardia. They can vagal from that. We call it a vagal reaction, so they can have bradycardia. So you don't want to cause that. But they'll have to be on some type of bowel regime to make sure that they are able to empty their bowel. So when we talk about GU complications or complications of the renal and urinary system, we really need to break it down into upper motor neuron lesions versus lower motor neuron lesions. So an upper motor neuron lesion is above L1, so your cervical and thoracic injuries. They're going to have spastic muscle tone. And how I remember this is when you're up or above, you're spastic, okay? Now, what you can do is pull or tug on pubic hair to get them to void. That's one of the interventions. The other thing you can do is, or you may have to do, is the bladder tone is so spastic they can't empty their bladder. So you might have to use intermittent catheterization. Now, initially, spinal cord injuries will have an indwelling catheter. However, we always try to get those out as soon as possible. It is better to intermittent cath, every 4 hours during the day than it is to have an indwelling catheter, because the longer you have an indwelling catheter, the greater the chance of infection. Okay, when you teach patients to go home and they have to cath themselves, it's a clean technique, not a sterile technique, because they get used to their own flora, so it's perfectly fine to do clean, intermittent catheter insertions. Now, you can also use the bladder scanner to check for urinary retention on the patients. Now, remember with spastic, they may leak a little bit with spastic muscle tone, but they are able to eventually evacuate. And then with lower motor neuron lesions, they have flaccid muscle tone. And how I remember this is when you're low, you're slow. Okay? And they can use Crede's method. I talked about this when I was doing the multiple sclerosis lecture. So they're unable to get the urine out, so they may have to press on their bladder to help it come out. And they may also need intermittent catheterization. So again, upper motor neuron lesions, you can pull hair. And how I remember this is if the patient is a spaz, I'm going to pull their hair. Or I'm going to pierce their bladder with a catheter. So that's how I kind of remember the difference between these two motor neuron lesions. Autonomic dysreflexia is a complication only in spinal cord injury patients that have a level of T6 and above. So they're going to be high risk for autonomic dysreflexia. So what happens is they get a severe throbbing headache and their face gets very flushed. Their blood pressure is so high, like really high. They have a 300% chance of getting a stroke, like during an episode of autonomic dysreflexia. They're going to be diaphoretic above the level of the injury. They'll have a flushed face above the level of the injury because the face is above the level of the injury, but they'll actually have not only a flushed face, but flushed skin above the level of the injury. They'll have piloerection above the level of the injury, which means goosebumps, and they'll have nasal congestion, which is above the level of the injury. So those are recognizing the cues of autonomic dysreflexia. Below the injury, the skin is going to be cool and pale. Autonomic dysreflexia is another complication, and this occurs in only in people that have a spinal cord injury at T6 or above. Okay, so it's triggered by noxious stimuli at T6 or below. So some examples of noxious stimuli could be having sex because it's friction, it's like noxious stimuli. Having a full bowel or full bladder, having a draft in your room, so, having a fan blowing on your lower extremities, tight clothes, a wrinkle in the sheet, or a belt that's too tight. So this is what happens. They can't feel the noxious stimuli, right? So this is the way of the body um, warning itself that they have noxious stimuli below the level of the injury because they can't feel it. So what happens is their blood pressure is going to go really high, and they're going to complain of a throbbing headache. Okay? Now, they're also going to have a flush face, and remember that flush begins with the letter F, because oftentimes you're asked, where is the flushing? And if you can remember, it's above T6. So they'll be flushed above T6. They kind of have distended neck veins. Their heart rate's going to go down, and they're going to have sweating above the level of the injury. Okay? Below the level of the injury, they're going to have pale skin. And how I remember this is if you can think of the male body, there's an appendage that begins with the letter P that is down below. Okay, that's how I remember which area of the body is pale and which area is flushed. So above T6, the body's going to be flushed. Below T6, it's going to be pale. It'll feel cool, and they will not have sweating below the level of the injury. So you have to be able to recognize it. I'm going to tell you what you need to do right away to save the patient's life on another slide. The triggers for autonomic dysreflexia can also be remembered by the 6 Bs: a bladder, a full one, a full bowel, boil, so that means skin irritations or pressure injuries, bones, fractures or bone injuries, below the level of the injury. Remember, these are all below T6. Babies, women that are pregnant. So if they're having a baby, that can trigger an event. And back passage refers to the anal area, so any kind of irritation or stimulus can trigger AD. If you have a patient with autonomic dysreflexia and the blood pressure is very high, the first thing you're going to do is elevate the head of the bed, because that's going to induce hypotension. Don't leave your patient alone. They're probably going to be very scared when this happens. You need to find the cause. Check the bowel, check the bladder, make sure there's no drafts in the room, make sure the fan is off. Um, and then, to prevent it, make sure you're straight capping every 4 hours so that they have adequate urine output. Make sure the urinary drainage system is not kinked up, and prevent constipation. You want to maintain room temperature. I talked about turning off the fan. And usually there's going to be like a PRN, hydralazine, or a calcium channel blocker or something ordered to get the blood pressure down. To prevent pressure injuries, you want to turn them Q2 hours in bed. You know that. Reposition them well. And then if they're in a wheelchair, at minimum, you're going to ask them to shift Q1 hour. But it's better if they can shift every 15 minutes while they're sitting in a wheelchair to prevent pressure injuries. A halo device is really an external fixator, so it's a type of traction almost. It stabilizes and immobilizes the cervical spine. Not everybody with an injury to the vertebrae incurs a spinal cord injury, but they could if the spinal cord is not stabilized. The vertebrae is not stabilized. So this is a halo traction, and if you look at the top piece, that's kind of like a crown around the head. That's why it gets the name halo. There are 2 anterior pins, and there's 2 posterior pins in the back. Only the physician tightens the pins. The nurse never tightens the pins. What the nurse does do is pin care daily, and you're going to use whatever solution, like hydrogen peroxide, chlorhexidine, whatever your facility uses. And you're going to do pin care daily. You're going to have separate supplies for each pin. So in other words, I wouldn't clean the first one and use the same cotton tip to clean the second one, right? So separate that and monitor for signs of infection. With the halo device, you're going to tape the wrench to the vest. This is in case of emergency. If your patient needs CPR, you need to be able to get that vest out of the way. Only one finger should be inserted between the vest and the chest. Okay, you don't want it too loose. Use straws when patients are eating, because they're not going to be able to move their head. They're not going to be able to turn like they normally do. Cut the food very small. The reason is you don't want them to choke on anything, because that's going to cause some problems with that Halo device. They should increase fiber and fluids in their diet because they're not going to be moving as they usually would. They're going to have less activity. They're going to have balance problems, so they're a fall risk. So make sure you understand that. They cannot drive with the Halo device. They can't turn their head. They can't see because of those rods. Sex is okay. They should maintain a position of comfort for sex, and the partner should be taught that they cannot grab the fixator during sex.